Hello, and welcome to Brewing Brilliance, a podcast where we talk to academics from across the university who are involved with the Healthy Ageing and Chronic Conditions Research Institute. We will be speaking to researchers who are leading innovative, interdisciplinary approaches to promote lifelong health, delivering improved interventions to manage chronic conditions more efficiently. These sessions are essentially opportunities for us within the Healthy Ageing and Chronic Conditions Research Institute to meet colleagues from across and beyond our faculty to foster knowledge sharing, collaboration and networking. Hello, my name is Adrienne Cleverly and today I am joined by Dr Jon Kennedy. Dr Jonathan Kennedy is a researcher who has over 17 years' experience employing data mining techniques on complex data sources to gain greater understanding of them and implement changes. He started his career in the steel industry, then moved to medicine. Since working in medicine, he has been involved with a diverse array of projects, including multimorbidity in maternity, arthritis, COVID-19, early years and intellectual disability. He has a wealth of experience utilising routinely collected data with machine learning techniques. So, hello and welcome. Thanks for joining us. So to start with, you've got an interesting background because you came from, like you said, like I just introduced, you came from that background of steel into what you're in now. Can you just give us a little bit of an overview around how that happened?
Yes. So my original degree was in material science and engineering, so like metallurgy and that kind of thing. And from that, I developed an interest for like data and doing analysis on the data with like data mining and that kind of stuff. And from that, then I did my doctorate with Tata Steel. In there. Then I was looking at like through process parameters impacting on tertiary scale formation in the process. So like what kind of inputs you're putting onto the process and what kind of outputs you're having out. And from that, then I went on to become an operational researcher there and looked at like throughout the process, looking at like the like raw materials all the way to like coating of things and what kind of data they got available and then like how to like process it and get results out and implement them in plant. And then there was an opportunity in the data science. Well, it wasn't even the data, that was pre-data science building, but
Pre-data science.
pre-data science. But like to do research using like routinely collected data, so like GP data, hospital data, and that kind of thing. And I felt like a lot of my like experience was like transferable to that, and I got that job, and I've been here ever since.
And here you are.
Yes.
So you work specifically, is it machine learning? Is that how we call it? Or
yes, yeah, mostly it's machine learning, but I do like more traditional statistics, and it's even with machine learning, most machine learning people who are involved with the data, they spend like probably 95% of their time working on the data and making sure it's suitable to actually perform the analysis, and then you just press go at the end.
So how is it being used then to improve our understanding of like multimorbidity and other complex health issues?
Yes. So with like morbidity, so that's like a measure of like how like unwell someone is, if they've got like mental health conditions, like anxiety or depression, or like bipolar and stuff like that, and also physical health conditions like arthritis, or other things like that.
Yeah.
And then so multimorbidity is like a combination of them. So the higher the number you've got, then the more complicated your thing is. And often you're going to have different conditions interacting in different ways and having different like priorities, because someone might have like arthritis, but they might also have dementia. So even things like getting to an appointment might become a lot more problematic for them, especially if they don't have a good support network.
Yeah.
So trying to understand those like complex relationships between these things of how like people interact with like the healthcare system and what kind of multimorbidity they have and how that develops over time.
And then to make improvements then, or?
Yes, of course. Ideally to make improvements.
Sorry, that came out wrong.
Yeah. So understand their complex history and to be able to like understand their particular like process through the healthcare, and how that can be like improved, and what kind of bottlenecks there might be, and that kind of stuff.
And then make changes then,
Make
I guess.
changes,
Yeah.
exactly.
So are there specific techniques or approaches that you're using, and how do they differ from traditional research before or
Yes. So we use like things like neural networks. We use decision trees is a technique where it's if you imagine like a family tree where you start at the top with like the total population,
Yeah.
and then like the depending on what parameters you put in, it will split the data on a particular parameter. So like 100% of things are on this side or that side, and then it will split further. So you'll have these like subgroups which are like, oh, like this group is like they've got back pain, and then they've got this condition, and then they've got this. So it tells you something about that group.
Yeah.
Which like if you're looking at something like arthritis, and like, oh, that group's, if you've got this thing, and this thing over these time periods, then you've got a higher prevalence of having that condition overall, compared to if you don't have this thing and you have this other thing.
So does that kind of change then? So you can almost predict.
Yes. So with that then, because we're looking usually at like entire population. So like if we're looking at like the Welsh population,
Yeah.
we would be with the Sale Data Bank looking at like all of the data in Wales, from like GP and hospital appointments, and seeing like when people are having like diagnosis put on their record, and when they're interacting, and seeing then from those things like how people are like comparable to each other or not via these kind of techniques.
Sorry to go off topic a little bit, but you mentioned the Sale Data Bank. For those that don't really know much about what the Sale Data Bank is, are you able to give us just a little bit of an insight into?
Yes. So the Sale Data Bank is a repository of data which has been anonymized, in particular from Wales. So we got like GP records, we got hospital records, we got like tertiary healthcare ones, all of which are like anonymized, and it's in a secure environment. So you can't just be like, oh, I want to look up Joe blogs and where they live and all of their details. No, it's all anonymous. So there is very secure things to like get data out and actually do the research in a proper way. So you can identify, okay, this is Joe blogs, but you don't know it's Joe blog. There's a code representing that person and how they interact with all of the different systems. So if they're in education data, or if they're in like law data, or if they're in healthcare data and stuff like that. So you can understand how this person interacts, but still have that person be anonymized in the system.
So does that help you then with things like with machine learning, and how you can generate like hypotheses and things like that?
Yes, exactly. So with machine learning, often how I utilize it is by we're looking at like potentially like hundreds of thousands of different like variables and like different parameters, and we want to kind of understand like what, when we use these techniques, what are the most significant ones. And then when we've got those ones, we can be like, okay, so within this population, like from the decision tree example, they got like this parameter and this parameter and this parameter. So like maybe we get that group in and try and understand them more, because we've got some like I said, the parameters of like they are these distinct groupings.
Yeah.
So from that, then we can better understand them, and
Yeah, go on.
better understand them, and better be able to implement changes which would hopefully improve their life, their quality of life.
And with that then, so that's kind of how you can identify multimorbidities and things like that. Is so in the context of healthy aging, why is it such an important area of research right now?
Well, the population is getting older. People having like less children. These problems are going to become more prevalent over the decades to come, as and also like people are less likely to be getting married, having children, like I said. So like now, like when my grandparents like started to, they were in their 90s.
Yeah.
They like the last like 10 years of their life, they were like relying on each other for a lot of support, and then on their children for support, and then right at the end for the NHS for support.
Yeah.
But if you don't have children, you don't have a significant other, then you're like, either the NHS is going to be like tremendously more expensive, because rather than like over the last 10 years or so, that like the NHS would need to pick up that full time when currently it was like the last like few months, year or so of their lives. And that would be for a much higher percentage of the population because people are getting older. There's a lot more elderly people as a percentage of the population, which puts greater pressure on like working age people as well, and like further reduces the chance of people having children, which makes the problem even worse in the future, and just like compounds and compounds like year on year.
Because it is an aging demographic, as you said. So the research essentially needs to evolve with how the population is changing as well, doesn't it?
Very much so.
Are there any particular clusters? I know you did touch on a little bit when you first started, but are there any particular clusters of of diseases within older populations that you see a lot of or less of? Or
yes, like certain things like dementia, of course more prevalent in like older populations, and also things like arthritis. I've done work before looking at like rheumatoid arthritis, but also looking at the impact of like where people are in Wales and in other parts of the UK to like healthcare settings. So if you're in a like Swansea or Cardiff, you're probably going to be very close. You can get like a bus, you can potentially walk or like cycle to a location to get healthcare assistance. But if you're in like mid Wales or something, you might know that there are some areas which, like, unless you have a car, which most people in mid Wales would probably have a car, but if you don't have like a car or someone who can drive you, then it's multiple hours to get to a thing, and you would need to be like, okay, I need to get a bus from my town to like a town and then out again and then out again, and it's not practical for most people then to get like regular like health checks and stuff like that.
Because you kind of forget as well, don't you? When you're in your little bubble, you forget that there are other more rural places or more,
Yes.
It makes a huge difference. Sorry, but you touched a little bit on some of the conditions there, but can I just ask you a little bit about arthritis and some of the work that you did on arthritis? Can you tell us a bit about that?
Yes. As an example, I've looked at ankylosing spondylitis, which is a condition where the spine like fuses. In particular, it affects young men. So when we've looked at those cases where like these people are diagnosed as having ankylosing spondylitis, look back through their history, we were finding that there was a lot of interactions with like, oh, they're coming in for mechanical back pain in their like teens and then early 20s, which in particular for young men is very unusual. So these things then can be used as a predictive tool. So if someone does come in with like, oh, you've got like mechanical back pain, you're coming in for like, oh, I've got these pains, across my body and stuff like that, then they can be sent for like a genetic test, which most people with ankylosing have this marker. But you don't want to send every single person to go there because it just like overwhelm those services. And the additional good thing with ankylosing spondylitis is if you do identify it early enough, there are drugs which can like essentially like stop the progression of the condition. But like normally or like historically, you've not been able to diagnose this until there's already damage, and especially because these are young men in their like 20s, 30s, that's like their entire life then, which is impacted, and they're not going to be able to potentially work or like have a normal life. But if you are able to be like, okay, when they were in their like teens or early 20s, be able to identify, okay, you've got a higher chance, you have these genetic markers, you can hopefully get them like identified earlier, and put on like the drugs earlier to stop the progression of the condition and the damage which would be incurred, so they can just have a much better standard of life then.
So and that's just like a simple healthcare access thing as well, isn't it? To make a huge difference to the way someone lives. What about some of the collaborations you've worked on then?
Yes. So I mentioned about like access to healthcare. With that collaboration, we were also looking at like Scotland and the rural levels in Scotland are like a lot more extreme.
Yeah.
Because like especially if you're in like the islands and stuff, you might I'd take like the best part of a day just to get to like the mainland, because you need to wait for a ferry, you need to progress like probably on a bus or something like that as well. Like so what they often do is have like mobile clinics which come meet people. So then they can have their treatments done and then it moves to the next place rather than having a centralized hub, because the distance for like the outskirts is just so extreme. Well, other collaborations when we've looked at like London,
Yeah.
it's a highly dense, it's much more dense than like Cardiff or Newport, and with they it makes a lot more sense to have like centralized locations,
Yeah.
because the relative distance is a lot shorter for people even at the extremes to get into a healthcare setting. Then
It's a classic case of like
Yeah.
one size doesn't necessarily
Oh,
fit
no.
all, because when you look at, like you said, the populations, and we mentioned like Mid Wales and Powys, and then you've got like
Yes.
we don't get a ferry anywhere, do we?
No, it's kind of like an interesting middle ground between like the extremes of both England and Scotland, with like very rural or very urban.
Yeah.
Um,
And you can't just like you say, what works in London doesn't necessarily work for those in Scotland. So it's
Yeah.
about how we can make sure that we have a bit positive impact on more than just
yeah.
one thing. So with findings like this, then, are they used to like inform service design or?
Yes, very much so. Like we've done work as well in like looking at when things have been implemented. Like there has been for people with intellectual disabilities,
Yeah.
like health checks. So a yearly like MOT to see how people are. Check through the list. Like, do you have this thing, and work with them in that. And we found that there was a great like reduced like death rate and other things for in particular for people with like Down syndrome and autism were like significantly lower if they were put on these health checks. And that's something which was piloted in Wales, and that was being like rolled out across England,
Wow.
just
So
because the amount of impact it can have onto these
massively
people's lives.
impactful then, and like you said, it's being rolled out. And
Yeah.
how does that differ then? That supports the rural theory then, really, doesn't
Yeah.
it? Because you're able to identify these things and, like you say, get it rolled out. Can you just tell us a little bit about that research with intellectual disabilities? You briefly just
Yes, yeah, and then
teased us with it.
all jumping all around the place. Yes, with that, so that's something we did a number of years ago for the intellectual. So we identified individuals with intellectual disabilities, including Down syndrome, autism, and various other conditions.
Yeah.
And then we identified which individuals were part of the trials, and then we compared like these individuals were part of the health check trials. They had codes to identify them as being involved, and also then the control group were the people who had these conditions but didn't have those health checks. And then we compared like their survival rate over time and stuff, and we found that it was significantly improved.
Just makes a huge difference, doesn't it? And
Yeah.
it's such a it's just funny that you think like just looking at these different sort of things can make such a big difference. And just putting people on things earlier, it's incredible. You've also worked on with health visitors, is that right?
Yes.
Yeah. And pregnancy and maternal. Can you tell us a bit about how your machine learning is involved with that type of research?
Yeah. So with the health visitor research, um, you know, um, because I've recently become a father, that was quite beneficial to like understand the data and actually haven't gone through some of the health visitor checks and stuff. So that definitely gave me a much greater understanding of what the data was being used for and what they were trying to collect. And from that, then we're able to look at the data and using some of these techniques, been able to identify like why some children were failing developmental checks at like 15 months or 27 months. And we found things such as deprivation, being more deprived, you were like twice as likely to have issues. Being male, you are like twice as likely to have issues. Having like autism in your history. So these children, at that age, at 15 months, at 27 months, they're not diagnosed as autistic, but like later on, they're potentially being diagnosed as autistic, and they were like significantly higher chances of having a fail, or like a non-pass at these development check. There was some issue. They were not having like the verbal communication skills or the like physical dexterity and stuff like that.
Does that help with the predictors then? Something like that?
Yes. So with that, then we, doing the analysis, we identified some of those things.
Yeah.
And then we could like dig into the numbers and see like what kind of impact that was having, and that was quite informative, especially because like a lot of the like some of the health visitors did suspect some things with autism, so but a lot of other ones were not, because normally you would be being diagnosed with autism like well after the period when the health visitors would be involved. So more when they're like 5 to 10 kind of range, rather than when they're like up to 3 or so.
And these early diagnoses can really support with their early years, can't they, in terms of when they do pick up so much in terms of their environmental and the society and things like that.
Yeah, and like how better to like prepare the children for life going forward, if it's possible to like get them on better programs and that kind of thing earlier, so you can alleviate some of the potential issues these children might be having when they are older, if you could put them on a different route and a different path then for life.
One that's more suitable to them.
Yeah, exactly.
So we talk about the potential, but are there any sort of limitations within this model of work?
Yes. The same with any kind of analysis. When any decision you make on the data, you are introducing a degree of bias into it. If you're looking at just males or just females or certain age groups, a lot of the time, like those things are stuff you need to do. Because like if you were looking at like rheumatoid arthritis, this is a condition which like more likely to affect you if you are a woman and are older. So if you were comparing that group who have got rheumatoid arthritis as majority, against the general population, the main things you're going to find as significant are going to be like, oh, they are older, they are female, which you already know.
Yeah.
But using different techniques to like case controls or like doing the population in certain ways, then when you run the analysis, then you can actually try and understand why that pathway is for like those comparable women to each other. Those kind of ages, rather than like more general stuff about the population. But and also in comparison to like other countries, being able to understand like how even being able to identify like code lists and stuff is very complicated. Like someone might have like even some like, how do we identify diabetes? Like in with the SAIL data bank, we've got like code lists for like, oh, they had a code for diabetes in the GP or in hospital. But other parts of the country might have like born in Bradford, they might have like questionnaires and like, do you have diabetes? And that's going to have a certain interpretation, because they may know they do or may not do, or might be a bit confused, especially with more complicated conditions. Mind you, also with more complicated conditions, the person might well know more about the condition than the person they're being interviewed by. Or you might have a charity which might have like a register of individuals with like something like diabetes or something. And all of which are going to be essentially like a part of the total potential population for people with diabetes. And because some people are not going to interact with healthcare very much. So they may well have diabetes, be like, I don't want to go to hospital, I don't want to go to GP.
Often afraid of the outcome.
Exactly. So there is like a total potential population for any condition, but you're just getting like a segment of it, and whatever like data you're looking at for that is going to give you like a certain answer. So being able to try and understand like how much of the total you're actually in is what I probably spend most of my time doing, really. And like how comparable it is to like other places, and because like we've like had some like discussions with like other countries as well. I believe in like Brazil and stuff, like a lot of their data was in like water purity and stuff, because like water sources were more of a problem. So when, the issues we've got are going to be like, oh, like people are getting older and getting less healthy as they age.
Yeah.
When other countries are in a position where they're like, oh, like we're not necessarily getting like water quality and like purity like consistently over time and stuff like that in certain areas.
Yeah. And again, that goes back to the demographics, really, isn't it? And about how different things are. So limitations are there, yes, but looking ahead, what excites you about where this potential can go?
Oh, well, there's just being able to like understand how different conditions like interact over time, and also one of the things which certainly I've seen, like looking at the data over all of the years I have, is that different people, even in Wales, are experiencing very different lives from each other. Some of the stuff we looked at with multimorbidity, like in pregnancy, younger women are having like about like at least like 30% or so which are having like depression or anxiety, if not higher in some groupings. So there's gonna be like some people who everyone they know has anxiety and depression, has various complicated multimorbidity, while other groups of people, I think, have like basically none.
Yeah.
So just like their life and their expectation and their experiences are just going to be like entirely different, just like and have almost no way, like no overlap potentially. So it'd be like just trying to bring the data together to like understand those kind of like networked like problems and stuff like that is something I'm interested in doing more in the future.
That does sound really exciting. And when you do get that on there, I want you to come back, because I definitely will be interested to hear more about that.
Me too.
We'll both be excited to see where it goes. Well, on that, thank you so much for coming in and joining us today. I've really enjoyed listening to that. Well, being part of it. I hope other people have enjoyed listening. But thank you for joining us. If you would like to find out more about this podcast or anything that we've talked about, you can find us at the Healthy Aging and Chronic Conditions Research Institute at Swansea University, and we've got Jon Kennedy, who I'm assuming they can find at Swansea Uni, but you can also come through us. But thank you once again for joining us. I did really enjoy that.
Thank you very much.
Thank you.